We will come to order. We meet today to consider the Better Mental Health Care Lower Cost Drugs and Extenders Act. This is a busy day in the Senate with many other committees also conducting business. So for the information of senators and staff, let me explain how I and Ranking Member Crapo would like to proceed. We each are going to deliver an opening statement. Other members are then welcome to deliver opening statements of up to 2 minutes. Once opening statements have been given, we'll introduce the panel and allow members to ask questions of the committee staff. After that, we will consider amendments to the mark. We're then going to vote on whether to report the mark. If a quorum for a vote is not present, we'll vote when we have a quorum. We'll let officers know the time of the vote to make sure that we do have a quorum. With that, we are going to turn to opening statements. I'll give mine. We'll turn to Senator Crapo's and then to colleagues. Today, we look at a package of health proposals that represents important bipartisan initiatives undertaken by the committee. And we work on several goals: expanding access to mental health care and mental health parity for Americans with Medicare and Medicaid, further reining in the shadowy tactics by pharmacy benefit managers that hurt community pharmacies and drive up prescription drug costs for seniors and taxpayers. We extend essential Medicare and Medicaid provisions that expire this year, and we shore up Medicare payments to physicians. I want to thank Senator Crapo. We've been partners in this every step of the way, and our colleagues. First, with this package, the committee is going to tackle unfinished business, working to guarantee that Americans everywhere can get the mental health care they need when they need it. As I travel my home state holding open to all town meetings, I continue to hear firsthand how badly people, and particularly young people, are struggling, and they are not alone. 1/3 of Americans have suffered or have a family member who has suffered a mental health crisis. Yet the U.S. Surgeon General, Dr. Vivek Murthy, testified in our committee that Americans experience an 11-year gap between the time they first experience symptoms of a mental health condition and when they finally get treatment. And then there's the substance use disorder crisis in our country. Overdose deaths in America hit a new high in 2022, fueled by the COVID-19 pandemic and the rise of fentanyl use. In response, the committee started in with hearings, requests for proposals, and a strong focus on bipartisanship. Last year, nearly 20 mental health proposals developed in the committee were passed and signed into law. The proposals we authored included measures to get more mental health counselors for kids in both schools and through telemedicine, more resources for community behavioral health centers, where my seatmate has done so much good. Thank you, Senator Stabenow. New benefits that cover family therapists in Medicare, and funding to train new doctors, including psychiatrists. Today, the Finance Committee builds on our record with additional mental health measures. For example, we have been working now to stamp off one of the worst ripoffs I have heard in a long time, and that is this question of ghost networks. Essentially what happens, and I want to thank Senator Bennett in particular, I know Senator Tillis and others have been working on this. This is outrageous because what happens is after people pay money to get a good mental health policy, essentially they can't get services, they can't talk to providers, they can't really get much of anything. There's really no there. And to really give you an idea how outrageous this is, when a person who has bought this coverage is in urgent need of care and goes somewhere else and has to pay extra, they get stuck with the bill rather than the people they originally contracted to get services with. So I'm really pleased Senator Bennett, Senator Tillis, my colleagues on both sides of the aisle are joining us in saying that these ghost networks are going to be a thing of the past. There are going to be real consumer protections in this bill. Insurers are going to actually have to cover what people have contracted for. That's what this is all about, honoring a contract, and it's high time. We've also made it easier for states to provide continuity in mental health and substance use disorder care for people in the justice system who haven't been convicted of a crime. We've included several provisions to help states working with neighboring states to expand telemedicine for mental health care providers. And this is basically bringing services into the 21st century, because we all know that if you cross over just a little ways into another state, you ought to be able to work something out in order to get some services, and this bill is going to help do that. We increased the kinds of providers servicing seniors to Medicare as well, and counseling services to them in the mental health area will be more widely available. The package builds on the markup that we had in July. We voted 26-1 to modernize the prescription drug programs and stop these PBM middlemen, stop them cold from heaping extra costs on seniors and taxpayers. And I want to thank particularly Senator Crapo. We have worked with all the colleagues on the committee, and I think now we really have a first-rate bill that's going to send a message for the first time in this $4 trillion health care system that we've got in America, that we're cracking down on middlemen. And I think that, too, is long overdue. So we've got additional work to do in terms of scores from the Congressional Budget Office. I want to thank Dr. Schwagel. He's been very helpful. We're going to consider proposals today, groundbreaking efforts that protect community pharmacies, for example. This is long overdue because they have been singled out for predatory PBM tactics and lower out-of-pocket costs for chronic disease drugs. The package is going to further root out the middlemen, and that is going to help steer America's prescription drug market towards a state of rationality and common sense, where the initiatives are always to focus on lower costs for patients and taxpayers. That's what we focused on, lower costs. Senator Crapo and I also have agreed to continue to work with the Budget Office on a proposal that's not in today's package. It's a proposal from Senators Lankford and Menendez that would make lower-cost biosimilars more accessible to seniors under Medicare Part D. We want to thank Dr. Schwagel. We continue to work with his office on getting the scores of the proposal, and we'll have more to say about that during the markup. Third, the package extends provisions of law that are set to expire this year. Makes no sense to wait until the last minute. Safety net hospitals and others that are doing so much good work for low-income folks obviously depend on it. We've also got another year of bonus payments to physicians who move away from the practice of fee-for-service medicine towards value-based care. A number of our colleagues have done good work on that. Senator Whitehouse is not here, or Senator Barrasso, but they've teamed up in a bipartisan way to promote those sensible payments that encourage quality and value-based care. Finally, the package provides a one-year increase to Medicare physician payment. Our goal is to shore up Medicare's effort in 2024 to boost payment for primary care. Next year, the Finance Committee will take a deeper look at Medicare physician payment, as several provisions in current law have to be re-examined. In doing so, we, again, are going to always come back to this lodestar where we're spending $4 trillion a year in health care. We've got 330 million of us. Divide 330 million into this $4 trillion, and you could send every family of four an enormous check, well over $40,000. So we're spending a lot of money. We're not spending it in the right places, and too much is frittered away on middlemen. We're not doing enough to address chronic diseases, and we'll talk about that in today's markup. And now I'm going to turn it over to Senator Crapo. I want to thank him for his cooperation, and all our members, Gesundheit, all our members have been involved in this effort, and we're going to hear from our colleagues after Senator Crapo.
Well, thank you, Mr. Chairman. 3 months ago, this committee took crucial steps toward improving health care access and affordability for Americans in all walks of life. In advancing the Modernizing and Ensuring PBM Accountability Act, we demonstrated the bipartisan conviction and momentum needed to move good policy from concept into law. At that time, the chairman and I committed to continuing our work on this prescription drug benefits. And with this markup, we honor that commitment. I want to thank Senator Wyden again for the partnership we've been able to develop. And as he's already said, this was a partnership with every member of this committee, working the way that a committee ought to work, to resolve differences and find common sense, bipartisan paths towards solutions that are needed in this country. And I also want to give a shout out to our staff. And I don't just mean the committee staff. I mean the staff of every member of this committee who have been working tirelessly to try to do what is now being done in this committee and get that bipartisan agreement put together. This is the way Congress ought to work. And I appreciate the opportunity to work with you, Mr. Chairman, on this legislation. Today, we are taking up common sense, comprehensive proposals championed by members across the dais to strengthen our federal health care programs. For 2 decades, Medicare Part D has served as a lifeline for countless seniors and Americans with disabilities, ensuring coverage for a wide range of safe and effective medications. However, market dynamics have shifted. Consolidation has constrained competition, comprised plan quality, and heightened the potential for conflicts of interest across the supply chain. Vertically integrated insurers merged with pharmacy benefit manufacturers, or PBMs, now account for more than 80% of the Part D market, up from just 30% in 2010. 4 PBMs manage benefits for 90% of enrollees. The 3 largest specialty pharmacies are all PBM affiliates, controlling more than 2/3 of specialty drug dispensing. In short, the market-driven dynamism envisioned with Medicare Part D's enactment has given way to an opaque, highly concentrated, and distorted pharmacy benefit landscape. This situation demands oversight and legislative improvement. Taxpayers and seniors finance the program. We are the client. We have a responsibility to promote accountability and improvement, particularly for the most vulnerable and highly in need Americans. Over the past 5 years, out-of-pocket costs for Medicare seniors have risen at nearly 3 times the rate for commercially insured consumers. According to a recent report from the Government Accountability Office, Part D beneficiaries pay more than their insurers for 79 of the 100 most highly rebated drugs under the program. The warped, distorted rebate system that dominates the program curbs access to lower-cost medications. It instead exposes patients to cost-sharing based on inflated sticker prices. In a perverse form of reverse insurance, discounts on medications used by the highest need enrollees cross-subsidize the healthiest seniors, with no direct savings at the pharmacy counter. Thanks to the tireless efforts of Senators Cornyn and Senator Tillis, among others, the legislation before us today would chip away at this outdated model, providing relief to patients with chronic conditions and capping cost sharing for all Part D enrollees at the net price of any given drug, inclusive of rebates. Beneficiaries would save on countless prescriptions, importantly, without premium hikes. Under policies led by Senators Blackburn and Lankford, seniors would also see increased pharmacy choice. Our bipartisan bill shores up the enforcement of pharmacy access protections. It would provide for a much-needed focus on independent community sites in medically underserved areas. With these updates, the committee's PBM reform legislation would adapt Medicare Part D to address these and other challenges facing today's seniors. Importantly, this comprehensive proposal would also pay for itself, upholding our bipartisan commitment to fiscal responsibility. Senator Cassidy's continued investment in cost transparency has proven crucial here. In fact, our legislation generates net savings, which we have reserved to account for any costs incurred under Senator Lankford's targeted biosimilar access policy, which we remain committed to advancing. Beyond prescription drug access and affordability, the bill before us reaffirms this committee's consensus-driven approach to health care improvements on a wide range of fronts. Mental health provisions crafted by Senators Cornyn, Thune, and Daines would drive care integration, improve telehealth access, and help to address workforce strain based on bipartisan proposals developed last year. Today's legislation also extends key flexibilities for states to ensure appropriate sites of care for behavioral health needs, thanks to leadership from Senators Thune and Blackburn. Under a policy led by Senator Barrasso, frontline health care providers would retain incentives to enter into value-based payment models. Clinicians would also receive targeted relief from reimbursement cuts triggered by the volatility of the physician fee schedule. Another vital policy extension championed by Senator Grassley would avert further cuts to doctors across our states, which could otherwise exacerbate ongoing shortages. Outlining every provision today would take more time than we have. Virtually all members of this committee have contributed in meaningful, essential ways to the patient-focused, fiscally sound, and evidence-driven final product. Senators across the dais have also produced a range of compelling amendments, creating a robust roadmap for further collaborative work moving forward. From enhancing access to groundbreaking early cancer screening technologies to strengthening the physician fee schedule through sustainable structural reforms, we have endless opportunities for meaningful, member-driven policymaking in the future. Specifically, one such amendment, the Medicare Multi-Cancer Early Detection Screening Coverage Act, which I lead along with Senators Bennett, Cardin, and Scott, has support from a majority of the Senate, including 19 co-sponsors on this committee, as well as from a majority of the House members, and from more than 700 local and national stakeholder groups representing all 50 states. Given this rare and broad bipartisan support, I look forward to working together to move this policy through this committee. This markup, along with our successful markup from July, provides an optimistic blueprint for this type of work. Today, I look forward to advancing this comprehensive deficit-cutting bipartisan legislation and working to pursue its full Senate passage and enactment. Thank you, Mr. Chairman.
Well said, Senator Crapo. And just listening to you, I'm also struck by the fact that, the history, particularly of programs like Medicare and Medicaid, when you innovate, almost always the private sector wants to pick up on it. So I thank you very much for your leadership and to all our colleagues. Senator Stabenow, you're next.
Well, thank you very much, Mr. Chairman and Ranking Member Crapo. And I'm really pleased and excited at another bipartisan markup that is really, I think, setting a wonderful tone for the Senate and for Congress. And so thank you for working together and working with all of us. And I'm also really pleased that we're continuing the committee's important work to address behavioral health and the behavioral health workforce crisis as we add more opportunities for people to get care in the community. We need more people providing the services, and so this is really important. I also very much appreciate Senator Daines. He and I co-chaired the workforce working group last year, and we put forward a draft that contained a number of provisions to expand behavioral health workforce and increase support for critical providers. And last year we did some of it. Our bipartisan legislation contained some of the policies, about 200 additional graduate medical education slots. I know Senator Menendez has another amendment that would expand that even further, which I think would be absolutely wonderful to do. But we also expanded coverage in Medicare for licensed professional counselors and marriage and family therapists, meaning more access to care for seniors. Today's legislation contains more of our provisions, including improving access to clinical social workers for seniors, increasing Medicare payments for behavioral health providers in areas facing shortages, and requiring Medicaid guidance on how to increase provider capacity in rural and underserved areas. I also, Mr. Chairman, want to thank you so much for including our amendment, Senator Cornyn and I, to add permanently a definition for certified community behavioral health clinics in the Medicaid program. So we added the funding last year to fully fund it, but it was still called a demonstration project. Now it is fully part of the definitions in Medicaid. These clinics are transforming the way we provide behavioral health care in the community, treating health care above the neck the same as health care below the neck, and including this definition is another important step forward in making sure that this is permanent. Many provisions in this legislation are excellent steps toward expanding access to behavioral health services in Medicare and Medicaid. I look forward to continuing to work with colleagues on expanding access to care, supporting our behavioral health providers, including ensuring that we have licensed clinical social workers properly compensated for the care that they provide, and that CCBHCs are also covered under the Medicare program. I've filed amendments related to these policies. Will not move them forward, Mr. Chairman, but look forward to working with you in the future on all of these. And so thank you again for holding this really important markup today.
Thank you, Senator Stabenow, and as the former chair of our health subcommittee, we know you are going to run to the finish line of this Congress, and look forward to working with you. Senator Cornyn's next.
Let me thank you, Mr. Chairman, and Senator Crapo for your leadership in putting together this important package. The Better Mental Health Care, Lower Cost Drugs and Extenders Act contains provisions that will improve the quality and availability of mental health services, lower the out-of-pocket costs for consumers, and provide relief for our safety net hospitals. I'm pleased to see the inclusion of the Complete Care Act, which Senator Cortez Masto and I have introduced. This policy will help improve access to mental health care in primary care settings by helping providers implement integrated care models like the collaborative care model. The collaborative care model has shown tremendous results in my state with multiple health systems like Baylor, Scott and White, and JPS Health Network, utilizing it to detect mental health needs of patients earlier and begin critical interventions. Additionally, the bill contains policies to help lower the out-of-pocket costs for seniors, as we all know, especially those with chronic health conditions, mirroring the Share the Savings with Seniors Act that I introduced with Senators Carper, Tillis, and Brown. I understand there were limitations to how broad this policy could be, but it's a crucial first step to lowering costs and better aligning incentives under Part D. So I want to thank you again, Mr. Chairman, you and Ranking Member Crapo for your support in including those provisions, and hope you will commit to continue to working with us to provide lower costs for our seniors, which I trust you will. I'm also appreciative of the Chairman and Ranking Member for their willingness to continue working on policies to improve access to lower cost biosimilars, something Senator Langford and Senator Menendez have championed. I'm hopeful we can see this finalized before the Senate passes this package. So let me again thank both of you, Mr. Chairman and Ranking Member Crapo, for supporting this legislation.
I thank my colleague for his good work. Next will be Senator Cantwell.
Thank you, Mr. Chairman, and thank you for this important markup on the Better Mental Health Care and Lower Cost Drug and Extenders Act. I want to thank all my colleagues for, again, working collaboratively and focusing on mental health. I very much support the Stabenow-Cornyn amendment that was part of this package on certified community behavioral health clinics. I think this has been a winning concept in the state of Washington, where I have visited, along with Senator Stabenow, the increase in capacity for mental health and behavioral health coverage by just adding capacity to already existing clinics. So can't get any better than that. And I'm glad that we're making that a more permanent program under this amendment. Second, I applaud my colleagues, Senator Crapo and Senator Wyden, for their continued focus on PBMs and PBM transparency. Couldn't ask for anything better than that right now, when literally pharmacies are being shut down by clawback considerations by PBMs and putting pharmacists out of business. So glad that the committee is continuing to focus on that. And then lastly, over the last 6 months, I have held many roundtables on the pressing fentanyl problem in our state. So I'm glad to see that this legislation will also provide a little help in that regard in the pretrial detainees to receive treatment for substance abuse. So very much appreciate that, and look forward to working with my colleagues on an amendment that we filed but we will not offer, that would continue to help us deal with that issue of getting people in treatment faster, but look forward to working with my colleagues on that in the future. But unfortunately, Washington has the dubious distinction right now of having the highest increase in fentanyl deaths over the last year. I think we're part of a border. Texas and Washington had the highest increases in fentanyl deaths in the country. We're both border states. We have a lot of transportation with our ports, but the fact that these, I was looking for the statistic here, these fentanyl deaths are just, Washington had the highest increase in 2022, roughly 500 additional deaths. The CDC reports that 109,000 people died of the drug overdose last year. So we have to do more to address the fentanyl crisis in America, and so I thank our colleagues for at least this small help in the fight.
And I also want to thank my colleague for a role in the PBM effort, because as chair of the Commerce Committee, you've been instrumental in terms of the transparency provisions. That's critical. What we've tried to do in this committee is deal with those programs where there's a substantial amount of federal spending, Medicare and Medicaid, in order to drive behavior in the healthcare system. But this is a team effort, and we thank you for all your leadership. Okay, Senator Thune is next.
Thank you, Mr. Chairman, and to you and Ranking Member Crapo for putting together this bipartisan package. This legislation builds on our previous work on PBMs and will help ensure that patients have access to community pharmacies and lower prescription drug costs, and it will extend a number of expiring policies in Medicare and Medicaid. I'm pleased to see several bipartisan bills that I champion, including in the modified MARC, including policies that will improve access to telemental health care, ensure patient access to durable medical equipment, and remove barriers for states to offer individuals access to substance use disorder treatment. The SUPPORT Act, which Congress passed on a bipartisan basis in 2018, included an option for states to provide substance use disorder treatment in institutions for mental disease, or IMD. Unfortunately, this option expired on September 30th of this year. I introduced the SAVE IMD Options Act with Senators Hassan and Blackburn to make permanent a state plan option in Medicaid to provide patients access to substance use disorder treatment in IMD. Individuals across the country continue to struggle with opioid and substance use disorders, and inpatient treatment can be life-saving. South Dakota and Tennessee have leveraged this state option to provide this critical treatment, and more states are likely to opt into this option if it is made permanent. So Chairman Wyden and Ranking Member Crapo, will you commit to including this IMD policy in the next vehicle that addresses expiring health provisions and prevent individuals from losing access to substance use disorder care in states that currently offer these services?
I intend to work very closely with my colleague, and we have several colleagues interested in this. This is a very important issue. I was just going over with Senator Crapo. Got a long history with Families First, and I just want to thank my colleague for being willing to work with us. And both I and Senator Crapo want to work with the several members of this committee who are interested, and I'll yield to Senator Crapo.
I would just echo the chairman's remarks. We will work hard to get this done.
Okay. Thank you. I've also filed an amendment to this markup that would make long-term reforms of the Medicare physician fee schedule. The underlying bill that we are considering today includes a one-year payment update for physicians in Medicare. And in recent years, Congress has provided a payment update to physicians after CMS finalized across-the-board cuts. When CMS makes changes to coding policies, it often triggers cuts due to budget neutrality requirements. Unfortunately, CMS's assumptions used for some of these changes often depend on incorrect utilization data and may not account for the fluctuation in the cost of equipment or staffing. Instead of Congress making payment adjustments every year, it's time we address the underlying issues and make long-term reforms to the physician fee schedule to ensure there is stability for physicians and the Medicare program for the future. Reforms to the fee schedule should be coupled with updates to incentivize quality. And I'm happy to join my colleagues, Senators Whitehouse and Barrasso, today in an amendment to extend the incentives for alternative payment models, but Congress needs to also make long-term reforms to encourage a greater move toward value-based care. So, Chairman Wyden and Ranking Member Crapo, I ask a second question, that is, will you commit to work with me and my colleagues to pass long-term reforms to the physician fee schedule and incentivize value-based care?
Senator Thune, once again, is being way too logical for some of these kind of debates. You got to get at this long term. And I think, Senator Thune, you made the point that doctors are the backbone of the system. In other words, we can fuss all we want about various things, but you got to have doctors. And absolutely, we are going to work very closely with you. And as you know, this also connects with an area that we've worked on for a number of years in terms of chronic illness. And Chairman Hatch was terrific in terms of leading us to protecting the Medicare guarantee and doing it by addressing chronic illness. And you got to have doctors to do it. So absolutely work closely with you, and I yield to Senator Crapo.
Thank you.
Again, I agree with Senator Wyden's comments. The physician's fee schedule has been broken for years. We've got to quit limping along and lurching and stopping and starting again and getting it fixed. I completely agree with the need for a permanent solution. We'll work with you to get that done.
Thank you. Mr. Chairman, I look forward to continuing to work with you on these policies and seeing them enacted into law, and I thank you.
Very good. Senator Cassidy's next.
I'm going to speak to the due process continuity of care provision. And I'm going to say, although I'm glad it's a first step, I'm frankly hoping that it's only a first step. I'll also say every now and then one of us, in this case me, your life work meets where public policy hits the road in this sentence, and I'd like to think we're going to do something good. Why? My life's work as a physician has been working with the Medicaid population, those who are in jail, and those who are either homeless or risk of homeless. And it comes to mind because there's about 430,000 Americans in jail every day who are not yet adjudicated, which means that they may be found innocent and be allowed to go home. But as soon as they are booked, they lose their Medicaid. So even though they are not guilty, ultimately, they lose Medicaid. Why is that important? Because when you enter a jail, and this is where my life's work comes to bear, they have a formulary of typically lower cost drugs. When somebody is mentally ill, and 44% of those in jail are mentally ill, when they go into jail and they're on a regimen that through trial and error has been found to control their mental illness, if those drugs are not on the jail formulary, they put them on an alternative and they are at risk of decompensating. Why does that matter? Because one, they're not guilty in some cases. They get discharged to the street, and instead of being reasonably well compensated, they are now on an ineffective drug regimen. They have to sign back up for Medicaid. They are at high risk of becoming homeless. And if you look at the homeless population, it is indeed a mentally ill population in large measure. So what does the provision do today? I'm glad we have it, but I hope it's only a first step. It says that for the first 7 days after somebody is put in jail, before they are adjudicated, when they are still technically innocent, they can maintain their Medicaid benefits, that they don't have to change their formulary, and if they are released within 2 to 3 days, which is very common, they don't have to re-sign up for Medicaid. But we limit it to those who have a substance abuse disorder. Now, about 3/4 of those with mental illness are co-diagnosed, but it leaves about a quarter of the mentally ill who will not qualify for this continued therapy. It does other good things. The substance use disorder, if you also have heart disease, well, you don't lose your Medicaid and you can go out and still get your heart disease. And it doesn't cost very much. Over 10 years, can you believe it? It's only $547 million, which I wish I was worth $547 million. I'm not. But around here, that's just not very much money. But I think it'll actually save a lot of money because folks will not decompensate, go to the street, and or be rehospitalized because they've lost their Medicaid coverage. Again, I hope next time we bring this up, it'll include mental illness, even for those who are not substance abuse, but I appreciate this is in. I think it's a good first step that someone who is innocent until proven guilty does not lose their medical benefits.
Thank you, Senator Cassidy. I'd go beyond your statement. I think it is more than a good first step. This is establishing an important due process precedent that we're going to have coverage, in effect, pre-trial. I look forward to working with you, and I think we ought to try to expand it in the days ahead. And let me yield to Senator Crapo.
I agree with, once again, with the chairman and with Senator Cassidy. There are a lot of provisions, very good provisions, that every member of this dais wanted to get into this bill that simply couldn't be fit in because of different considerations, sometimes cost, sometimes policy disagreements that could not be resolved, but this is one we need to resolve. I agree to work with you.
And one to build on. I've had conversations with a number of colleagues on both sides of the aisle, and all of us try to focus on one area, and since Gray Panthers, I've always said this is the most important. And if we can get these new policies in place so we can build on them in a bipartisan way in the years ahead, that'll be a real statement about them making a contribution on our watch. So thank you, Dr. Cassidy. Our next speaker will be Senator Bennett.
Thank you, Senator Cassidy, for your bill as well. I think that's an important step forward. Thank you, Chairman. Thank you, Ranking Member Crapo, for holding this markup on really important legislation to address our mental and behavioral health challenges and high drug costs. I am pleased the underlying legislation includes my bill with Senator Tillis and Chair Wyden, the Real Health Providers Act. As the mental and behavioral health crisis ravages our communities, Coloradans tell me they struggle to find the mental health services they need. This crisis is especially prevalent among seniors covered by Medicare, a quarter of whom live with mental illness and less than half of whom receive treatment. Too often, Coloradans enrolled in Medicare Advantage plans rely on the plan provider directory to find a doctor covered by their plan, but out-of-date directories make it impossible to find active providers. And these inaccurate directories are known as ghost networks because doctors listed in them are either out of network, not accepting new patients, or in some cases, no longer in business. For seniors, in particular for seniors living in rural areas, ghost networks make it more difficult for patients to find in-network healthcare providers, an issue that is more acute in the mental and behavioral health fields than in any other field that we face. These outdated networks can lead to unexpected costs, or in some cases, delayed patient care or no patient care. My Real Health Providers Act will strengthen requirements for private Medicare Advantage plans to maintain accurate provider directories. It also ensures seniors do not pay out-of-network costs for appointments with doctors who are inaccurately listed as in-network in these directories. In the richest country in the world, seniors should be able to make informed decisions about their health insurance. And the Real Health Providers Act takes common sense steps toward transparency in the Medicare Advantage program. I want to thank Senator Tillis again for his bipartisan work on this. I think it's going to bring us a huge step forward. And Chairman Wyden, thank you for your leadership on this. I want to mention one other thing. The underlying legislation we're considering today also addresses the critical issue of hospital reimbursements by extending DSH payments for 2 more years. DSH payments are critical to safety net hospitals across Colorado, especially those serving the uninsured and underinsured populations, and again, those in rural areas. While these payments are important, I continue to hear, and what the work we're doing is important, I continue to hear, as I mentioned, Mr. Chairman, from Colorado's safety net hospitals, that they're struggling to stay afloat. One hospital in Colorado told me that it faces $30 million of uncompensated care because they're willing to take patients that other hospitals are unwilling to take, and because it has more expenditures as a super safety net hospital that other hospitals do not. Our current DSH program does not cover those expenditures. I've heard similar things from rural hospitals as well, and I just want to thank you, Mr. Chairman, for your attention to this, your willingness to have conversations about this. I think we need to find an imaginative bipartisan way forward on this, so I thank you for that, and I look forward to supporting this legislation.
Thanks very much, Senator Bennett, and you are highlighting such an important issue. I mean, it really starts with insurance companies burying the hospitals and doctors and patients in mounds and mounds of red tape. And then we go into other areas, the denials, the ghost networks, and the like. In my state, in the eye of the COVID epidemic, we saw a tremendous increase in the number of claims that were denied. And finally, it got to the point where I actually just put out a press release saying I was investigating it, and then suddenly all the claims got paid. We've got to have a better payment process than getting bills paid when a member of Congress starts screaming about it. So I really appreciate what you and Senator Tillis have done. We're going to build on it in the days ahead, and I thank you for your leadership. Let's see, Senator Menendez would be next in line. He was out of the room.
Mr. Chairman, I'll reserve my time for my amendments.
Very, very good. So next would be Senator Langford.
Mr. Chairman, thank you. The chairman, the ranking member, thanks for all the work that you've done and your staff. There's been a lot that's gone into this. There are quite a few what I would call radically helpful policies that are into this as we walk through it. We have issues on reducing the cost of drugs at the pharmacy counter for seniors. We have items here that provide a lifeline for independent pharmacies to make sure they actually stay afloat and stay in our rural communities. We have issues in here that deal with some of the reimbursement cuts for providers to be able to make sure we maintain providers. As my colleague Senator Bennett just mentioned, the disproportionate share hospitals that provide for some of our folks most at need, making sure that we actually keep those afloat. and then also increasing access for mental health. Those are all incredibly important things that need to be covered, that this has been a long time coming to this. I do thank the team as well for all the work on so many different types of issues there. There's also been an ongoing conversation about the issue of one of my bills, ensuring access to lower-cost medicines for seniors. I appreciate the committee for including that in the discussion draft. I'll talk more about that later on as we walk through this. Senator Menendez and I and our teams have worked extensively on this, literally for years, to be able to get this done. We work with CBO extensively on some of the scoring issues, try to get there. We're not quite there to be able to get final scores. It is a complicated issue, but it's not complicated for the people at the counter. This will ensure lower costs for individuals that are purchasing drugs and an increased number of biosimilars that are coming out to, again, drive down the cost at the counter. So there's no question it will increase the benefit to Americans all across the country, and we're grateful that that's been included in the discussion draft today. I'm also really encouraged to be able to see us add many of the policies from my bill, Protecting Patient Access to Pharmacies Act. This deals with the DIR fees that most Americans know nothing about, but this committee spent quite a bit of time digging into, and the real detriment that is, giving this unpredictable fees, which has literally driven many independent pharmacies out of business. So the work that's happening today will not only ensure independent pharmacies exist, but will also make sure that some independent pharmacies are actually listed as independent pharmacies. They get a chance to be able to be on that list. It also protects different pharmacies from mid-year changes, and there's current policy there where they can't make a complaint. If the PBM makes a change in the middle of the year, they just can't complain about it until the next year. Well, this allows that communication to be able to flow, and then also deals with multiple different issues on the reimbursement side. Right now, literally pharmacies can be reimbursed for less than their actual cost for a drug based on the pressure from PBMs, so that PBMs are successful and pharmacies are not. We've got to allow them to be able to survive and thrive. So I appreciate all the work that's gone into many complex issues.
Thanks very much, Senator Langford, for how you've worked in such a constructive way with Senator Crapo and I. We're going to have a broader discussion on the colloquy issue that we have worked out. But I also want to thank you for standing up for these small independent pharmacies, because all over the country, we're seeing lines at pharmacies now where there weren't pharmacy lines before, and it's because the PBMs ran these little guys out. So I really thank you for your leadership, and we'll have your colloquy here in a bit, and that'll start moving us again to final resolution. I appreciate it. Next is Senator Hassan.
Well, thank you very much, Mr. Chair and Ranking Member Crapo. Thank you for holding this markup today on critical issues facing our constituents all across the country. We appreciate your leadership on these and other issues. And before I speak to Hassan-Blackburn Amendment 1, and while it's not within the scope of this markup, I will say that I look forward to continuing to work with both of you on our shared goal of restoring critical research and development tax incentives while also expanding the child tax credit in ways that both encourage work and reduce the number of children living in poverty. Now, regarding today's agenda, I will speak to the Hassan-Blackburn Amendment number 1 now, and later this morning to the Hassan Amendment number 2. On Hassan-Blackburn number 1, the evidence is clear that medication-assisted treatment, otherwise known as MAT, is the single best, most effective option for treating patients with substance use disorders, the gold standard of treatment. But guaranteed coverage of this essential form of treatment through Medicaid expires in 2025 unless we take action. My bipartisan amendment with Senator Blackburn would address this cutoff by continuing to require state Medicaid programs to cover medication-assisted treatment beyond the current 2025 expiration. This amendment does not expand the kinds of treatments that we currently use to address opioid use disorder. It does not require anything new of states. It simply maintains current coverage of life-saving medications, medications that have been used safely by thousands of patients and their doctors for years. Our conversations about this policy over the past few weeks have been positive, and I understand that members of this committee are aligned in continuing this policy and ensuring that it does not expire in 2025. But the committee has requested that we hold off on voting on this policy for now and continue to work on it together, something I am amenable to doing with appropriate assurances to help ensure that we can do this and do it right. So Chair Wyden and Ranking Member Crapo, if I agree to withdraw this amendment today, will you commit to working with me to expand this essential coverage for medication-assisted treatment before it expires in 2025?
The answer is I will continue to work with you, and let me give a joint thank you to you and Senator Blackburn, who is also here, because both of you have worked very closely with Senator Crapo and I, and you've shown, I think, the right kind of leadership on medication-assisted treatment for opioid use disorders. We know that medication-assisted treatment is one of the most effective tools that is out there to fight the opioid epidemic. And it's not just a New Hampshire issue or an Oregon issue or a Tennessee issue. It is a national issue. A national issue, and making access to this treatment permanent in Medicaid, in my view, is going to save lives. So I want you to know we're going to keep working very closely with you and with Senator Blackburn. And I gathered that this involves your first proposal, and I wanted to get a joint thank you to both of you now because you deserve it, and we're going to keep working with you.
Thank you.
Senator Crapo, want to add anything?
Again, I agree with the chairman, and I just want to add that, as I said earlier, there are a lot of proposals. There were 56 amendments to this bill, and every one of them was something that we really wanted to look at. We just didn't have the ability to fit everything in with the cost constraints, as well as with some of the, as I said before, some of the policy disagreements that we needed to resolve. The bottom line here is your proposal is one we need to take a very hard look at, and we will be working on it as we move forward.
Thank you.
Thank my colleague. Senator Tillis is next.
Thank you, Mr. Chairman, Ranking Member Crapo, members of the committee for working together on this. And again, a special thanks to the staff. You know, every time that we say I up here, we really mean we, because we know the lion's share of the work is done by so many of you on the committee and in our offices. But this is a great opportunity. We're going to move forward on advancing mental health, PBM reform, and the traditional health extenders. Senator Bennett's already talked about the Real Health Providers Act. I tell you, I'm watching all these commercials right now. I know everybody is on annual enrollment, and I just wonder how many millions of people are going into ghost networks not getting an accurate picture of their provider choices. We need to make sure that they need to, we've got to make progress there, but we've got consumers right now that are making those choices. It'll be great to see this get into place. Also, the Share the Savings with Seniors Act, something that I've worked on with Corn and Carper and Brown. Glad to see that in there, along with the chairing proposal from Senator Langford. You know, I'm glad to see that we're going to avoid some drastic cuts, or maybe mitigate or prevent some drastic cuts. Particularly interested in progress we're making on clinical laboratories, physicians, disproportionate share hospitals, to name a few. The package builds on the progress this committee has made over the summer with modernizing and ensuring PBM Accountability Act. We've got a lot more work to do. But I'm also looking forward in the future. I'm not going to look for a commitment because, Mr. Chair, you've impressed me working on a bipartisan basis that we got to work through the thorny issues. I don't need a commitment from you. I've seen it evidenced by this markup, and I expect to see other ones. But we do have to work on other priorities, such as permanent clinical lab fee schedule mix, structural reform to the physician fee schedule, and increased flexibilities to allow foster care children to receive mental health care. I look forward to working with you on it. I think if we work together, we'll come up with bipartisan progress. And thanks again for the work you've done to produce this markup.
Well said, colleague. And ever since you got on this committee, you've made it clear that you want to be part of this effort, particularly to tackle health care in a bipartisan way. And it is so important because that's how we're really going to make major progress. And I thank my colleague for his kind words and especially for working with us. We're going to continue this bipartisan tradition. Next is, let's see, Senator Cortez Masto.
Thank you. I too want to thank both the chairman and ranking member and my colleagues and all the staff for the hard work that you've done in putting this incredible package together. This committee clearly has taken another important step forward today in our ongoing bipartisan mental health work by addressing challenges with workforce and service access. And I appreciate the inclusion of the Complete Care Act legislation that Senator Corn and I worked on together. It's in the chairman's mark. Thank you. I am proud of that bipartisan work as well as the work that's gone into this package as a whole.
On behavioral health integration, the fact is our current specialty mental health care delivery service cannot meet the service demands of the pandemic and beyond. Many people cannot get in to see a specialist for their mental health care, and that's increasingly made primary care the place people turn to get the help they need. In Nevada and across the country, access challenges have been exacerbated by ongoing shortages and a general lack of care coordination. That's why Senator Cornyn and I introduced the Complete Care Act, bipartisan legislation that would expand behavioral health care available to Medicare beneficiaries in primary care settings. By incentivizing primary care to adopt and implement integrated care models, the provisions in our bill will improve access to timely and effective behavioral health care. Integrated models like the collaborative care and primary care behavioral health are incredible tools to support coordination, but we have seen the costs associated with implementation limiting the uptake of these models by primary care practices. The Complete Care Act provision in today's MARC addresses this issue by enhancing Medicare payment rates for collaborative care and behavioral health integration services. Importantly, these integrated models are proven workforce extenders. When mental health specialists join a primary care setting, they can share their mental health expertise with even more patients seeking care, and that patient is backed by a team of specialists. So I thank the committee for the attention to this issue. I also have to do a shout out to our mental health providers, our patients and advocates who have been tremendously supportive of this legislation and who helped us get here today. I hope also that as we make progress on the committee's broader bipartisan discussion draft, we also continue including the efforts that Senator Cornyn and I have worked on to expand access to crisis stabilization services. And then finally, before I close, Mr. Chairman, I want to mention I have also filed an amendment joining me with Senator Cornyn to improve Medicare's reimbursement of mobile crisis teams and enable peer support specialists to provide that crisis care. I'm not calling for the vote today. The policy is a priority for the coming year. I look forward to working with the chairman and ranking member. I hope there is a commitment to continuing to address the crisis side of this. It is just as important. And to that end, I am actually seeking CBO score of this provision so that we can better understand the cost of Medicare reimbursement for mobile crisis teams. So thank you.
3 cheers for bringing up Medicare in this mobile crisis debate, because as you know, we got started with Medicaid. We've got a lot more to do because all over this country, this question of mobile crisis units is increasingly serious and homeless and related to a whole array of mental health issues. And I look forward to working with my colleague. And Medicare crisis, absolutely. Let's go to Senator Blackburn, and let me tell my colleagues where I believe we are, having consulted with Senator Crapo. We've got votes coming up at 11:30. With a little bit of luck, we can finish this bill, even with all of our colleagues getting both their opening statements and the colloquies we're going to have. We can get it all done before we go vote. So I thank my colleagues for their patience. Senator Blackburn is next.
Well, and I thank you, Mr. Chairman, and Senator Crapo for the markup, and I think it is significant that once we vote today, we will have passed the most significant PBM reform legislation of Congress. So we thank you for that. And as you know, I've led on the bipartisan PBM Act, which will finally delink that middleman compensation from drug prices, ensuring that the PBMs prioritize our seniors. And I would like to submit 3 documents for the record.
Objection so ordered.
Thank you. The first is a letter from the National Association of Manufacturers endorsing this critical delinking proposal. The second, Blue Shield of California, showing payer support for the common sense policy. And third is a study that from respected researchers underscoring the importance of these reforms, which will save millions in taxpayer dollars. I also want to express appreciation for the Better Act's inclusion of my bipartisan No PBMs legislation. Pardon me. And that will transform basic pharmacy access protections into more than just a piece of paper, a good thing. As PBM affiliates dominate the pharmacy sector, community providers across Tennessee are struggling to keep their doors open. They are buried in abysmal payment rates and bureaucratic paperwork. This proposal would bring much-needed certainty and relief to pharmacies across our state in rural communities that are plagued by cartel-like PBM practices. Medicare Part D should serve seniors and Americans with disabilities, not consolidated contractors that have moved us closer to single-payer health care. And I look forward to continuing to work on these critical reforms. I also thank the chair and ranking member for including a much-needed payment increase for our doctors. With that said, I would like to emphasize that these annual interventions by Congress to provide short-term payment increases is unsustainable. Mr. Chairman, I was pleased to hear you echo that in your remarks. I would also ask the chair and ranking member to work with me on common sense solutions to create payment certainty for providers and put Medicare on a sustainable path forward. Last, I commend the necessary steps the legislation takes to strengthen mental health care and address the ongoing opioid abuse crisis touching every community in my state. This includes the bipartisan SAVE IMD Act that would permanently reinstate the Support Act's SBA option for states to provide patients with substance use treatment in an IMD. And I thank you for your response to Senator Thune on that as we keep working on this issue. I look forward to continuing to work on these, and I appreciate today's markup.
Thank you, Senator Blackburn, and thank you especially for all your help with the PBMs. I remember our early conversations on the floor, and your leadership's been much appreciated. Here's where we are. We got to finish our opening statements. We've got several colleagues on that. There's a Langford question for the Congressional Budget Office, 5 colloquies, and we'll vote. And the goal is to get all this done before we have votes on the floor. Senator Daines is next.
Chairman Wyden, thanks for your great play-by-play leadership here today. It's appreciated. And thank you for facilitating today's markup, as well as Ranking Member Crapo. Well, we're all aware of the devastating mental health crisis that our country is experiencing. Caring for our mental health has received increased national recognition in recent years following COVID-19, but it deserved widespread attention long before the COVID pandemic. Today, the mental health challenges in America are exacerbated by rising levels of isolation, of loneliness, of substance abuse disorders, of addiction, depression, anxiety, and perhaps most notably, the lack of access to care, especially in our rural areas and rural states. In Montana, we are seeing one of the largest increases in suicides nationwide. Fentanyl use in the state has claimed hundreds of lives over the past few years. Attention to mental health is needed now more than ever. The legislation we are considering today explicitly targets the lack of access in several ways, including bolstering telehealth, addressing coverage gaps, and strengthening the mental and behavioral health workforce shortages. I'm grateful to say that a number of policies in today's markup build upon the work that Senator Stabenow and I began last Congress with our colleagues in the Senate Finance Workforce Working Group. Those policies and a number of others reflected in this legislation are the direct results of intentional, bipartisan efforts to expand mental health and substance use disorder access and services within our federal health care programs. And I'm glad for this committee's continued focus on these most important priorities. Also in today's markup are policies that build on this committee's previous work on pharmacy benefit manager reforms, as well as addressing exploring provisions and funding within the Medicare program. I'm glad to say the package is entirely offset. I'd like to thank the chairman and the ranking member for their fiscal responsibility in ensuring that the policies are paid for. Not an easy task. And thank you for your work there. With that, I look forward to moving this legislation out of committee. Mr. Chairman, thank you.
Good. Thanks so much for working closely with us. Next will be Senator Carper.
Thanks, Mr. Chairman. I want to thank you. I want to thank Senator Crapo for bringing us together, holding this markup, and especially for continuing to focus on lowering prescription costs through PBM reforms, as well as continuing our work to improve mental health care across the country. As my colleagues know, Mr. Chairman, I go home almost every night. Usually take the train, but earlier this week I had to drive because it was late. And I stopped at a Wawa just before I went over the bridge between the Connect Stellar and Maryland. And a fellow who was from Maryland said to me, he said, he recognized me. And he said, even though he's not a Delaware, he said, why can't you guys just work together? Yeah, why can't you guys just work together and get something done? I hope that guy's watching today, because every single initiative that we've been talking about here has bipartisan support. And I think that flows from actually the way that the kind of leadership that, Mr. Chairman, that you and Senator Crapo are providing. So thank you for that. I'm grateful for that several proposals that I've offered have been included in the chairman's mark, including a provision with Senator Cornyn, Senator Brown, Senator Tillis, and that will protect seniors from excessive cost sharing for chronic condition medications. For far too long, pharmacy benefit managers have also been left unchecked, pocketing rebates from manufacturers rather than passing them on to patients. One of my guiding principles is particularly when it comes to drug pricing policies, make sure, as others have said, that the lower costs are actually passed on to consumers. This important provision that I mentioned will do just that by ensuring seniors with chronic conditions directly see the savings that PBMs negotiate on their behalf. I'd also like to thank our chairman, ranking member, for the inclusion of several proposals that I've offered with Senator Cassidy relating to improving youth mental health. Senator Cassidy and I co-led the Youth Mental Health Working Group, where many of those ideas originated, so I'm delighted that they are going to be moving forward today. We're currently facing a national youth mental health crisis. Our work is yet to be done, and these provisions take an important step in improving the health of our children. Mr. Chairman, I got to go back and finish chairing the Environment Public Works. I could just, if I could, just with respect to Senators Sullivan and I have an amendment that's going to be offered later today, the Kids Health Act, an amendment that would take, I think, important steps to improve the health and well-being of children and youth by addressing non-medical factors that influence health, social drivers of health, such as access to nutrition, food, mental health services, transportation are particularly profound for our children and are linked to disease burdens across adolescence and adulthood. The amendment would support states' efforts to establish whole child health models that integrate social drivers of health and mental health supports into health and care delivery for children under Medicaid and CHIP. And while I'm withdrawing this amendment, I look forward to working with Senator Wyden, Senator Crapo, to advance this important provision. With that, I yield back whatever time I might have. Thank you for letting me go on and on. Thank you. And to our staffs and everybody that's worked so much on this, God bless you. You're doing the Lord's work. Thank you.
I thank my colleague. Next is Senator Grassley.
Yeah. Thank you, Chairman and Ranking Member, for holding this meeting. There's several priorities of mine in this package. Most importantly, the extension of the Medicare Geographic Practice Cost Index 4. That goes by the acronym GYPSY for short. It supports physicians in rural states. While not in this bill, I hope this committee will keep working to ensure that CMS uses the most recent physician labor data for GYPSY updates. We also need to take a hard look at the existing 36 states that have statewide regions for physician payments. We need to make sure that the statewide regions reflect the current cost of physician labor in our rural states. I'm glad that we're advancing mental health provisions, but I urge the chairman and ranking member to consider provisions in my bipartisan Healthy Moms and Babies Act. Addressing the mental health needs of moms can improve our maternal and infant mortality rates, which are going in the wrong direction, as been recently reported. We can also improve the mental health of kids with complex medical needs and their families by passing the Accelerating Kids Access to Care Act. I'm also glad that this committee is advancing the additional PBM accountability and transparency provisions. This committee included 5 of my PBM provisions in the July PBM markup, and I look forward to advancing that on the Senate floor. While the committee continues to get technical feedback on my delinking compliance amendment, I want to reiterate my priority for including this in the final package. It's critical that someone in the prescription drug supply chain, like the pharmacist, can report noncompliance directly to CMS. I've heard firsthand from rural pharmacies about the looming cash flow challenges that they face next year. Without rural pharmacies, seniors will be facing access issues for their medications. This is a situation that I'm sure everybody knows. Pharmacies are going to face direct and indirect reimbursement clawback fees from PBMs for calendar year 23, just after January 1st of the coming new year. At the same time, pharmacists are also going to face lower post-point of sale reimbursement from PBMs beginning that very same day, January 1st of our coming new year. I spoke about these cash flow problems at our July markup on the Senate floor, and thirdly, in 2 letters to CMS. I ask unanimous consent that you put both of my letters into
Without
the record.
objection, so ordered.
I've also spoken to the CMS administrator and arranged for Iowa Pharmacy Association to speak with the agency. CMS said that they were, these are their words, particularly attuned to the cash flow problems. Until this last Monday, we've seen no action to match those words. I'm glad that CMS finally used its bully pulpit and issued a memo to all Part D sponsors and PBMs that acknowledges the cash flow issues rural pharmacies face next year. CMS reminded Part D plans of prompt payment requirements and pharmacy access standards. I'm glad that CMS wrote that these are their words, strongly encouraged Part D plan sponsors to provide payment plans. This is what I've been asking the agency to do for many, many months. Despite all this, CMS continued oversight and engagement with Congress is critical. CMS cannot sit on the sidelines and let rural pharmacies go out of business. I'm glad my amendments to conduct this oversight over CMS and hold PBMs accountable was included in the chairman's mark. Finally, I've filed several amendments today on establishing price transparency in prescription drug ads, improving maternal mental health, establishing pharmacies provider status, and supporting kids with complex medical needs. I hope the chairman and ranking member will keep working with me to advance these priorities. Thank you.
I thank my colleague. Thanks for the really good work on PBMs. I just tell colleagues we're really sprinting to get this done before we vote. So if we can stay with the 3 minutes, that'd be great. Senator Brown, you're next.
Thank you, Mr. Chair, and I will do that. Thanks to the Affordable Care Act and other more recent laws like the RRA, the American Rescue Plan, we made a lot of progress in improving access to health care. Despite this, we know insurance companies, PBMs, Big Pharma, continue to engage in harmful practices and price gouge consumers, whether driving up the cost of prescription drug costs, creating barriers to mental health services, causing unnecessary losses of health care coverage. As a result, many people continue to struggle when it comes to accessing timely, affordable health care, and those serving them, from doctors to every pharmacy, are hurt too. I'm pleased that Senator Wyden and the Finance Committee have been committed to addressing many of these issues bipartisanly. I look forward to working with the committee on a number of my priorities they include in the markup, such as helping to lower the cost of prescription drugs, protecting rural independent pharmacies, and holding PBMs accountable. I'd like to thank the chair and ranking member for incorporating 4 of my amendments. I will briefly go over them. I won't ask for a vote on either those priorities today. I'd like to continue to work with you to advance these bipartisan policies, Mr. Chair. First Amendment, Brown Amendment number 3, would ensure that vulnerable individuals don't unnecessarily lose access to their Medicaid and CHIP coverage. Each year, millions of Medicaid and CHIP beneficiaries are at risk of losing coverage because they take an extra shift working overtime and their income fluctuates, certainly not honoring the dignity of work. For nearly 1 in 5 Americans on Medicaid who have a substance use disorder and may need access to timely care, they can't afford a disruption. Last year, we were able to work in a bipartisan way to make it possible for children eligible for Medicaid and CHIP to remain covered for 12 months at a time. My amendment would build on the bipartisan work we did at the end of last year. Second Amendment, Brown Amendment number 4, is priority for law enforcement. We know that individuals re-entering society after incarceration are extremely vulnerable to experiencing struggles. Believe it or not, 129 times more likely to die from an overdose post-release. We can prevent these individuals from overdosing if they have access to health care coverage upon release. We can start up on treatment as they start their reentry process. That's really the key. The Medicaid reentry bill I've worked on with Senator Baldwin is bipartisan legislation. It would restart Medicaid coverage for eligible individuals 30 days, think about this, 30 days prior to the release, ensuring that individuals have smoother transitions into the community. These amendments would break down real barriers to accessing mental health and substance use disorder treatment. Chairman Wyden and Ranking Member Crapo, thank you. I look forward to continuing to work with you on a path forward for these priorities. Thanks so much.
Thank you for your good work for working families. Senator Brown. Senator Casey's next.
Mr. Chairman, thank you, and thank you, the Ranking Member Crapo, for your work to produce a bipartisan bill for the markup. This bill demonstrates that the committee and the Senate itself is continuing to do the work of the American people by lowering drug costs for seniors, protecting access to care, and increasing education assistance for low-income Medicare beneficiaries. I'll support the legislation, and I would also like to highlight some of the provisions that I worked on. I was pleased to see the bill included an amended version of Senate Bill 2456, the Protecting Seniors from High Drug Costs Act, which I introduced to Senator Cornyn earlier this year. The provision would prohibit plans from charging patients cost sharing that is more than the negotiated net price of a covered drug in Medicare Part D, saving money for seniors. I want to thank Mr. Chairman, you and the Ranking Member and Senator Cornyn for your commitment and your work on this important issue. This bill also includes a 2-year delay of the Medicaid disproportionate share hospital cuts, so-called DISH cuts, which Senator Langford and I led 49 of our colleagues to support, and we both pushed Senate leadership on this issue as well. This will help to ensure the financial viability of many of our nation's safety net hospitals. Without the provision, access to care for some of the most vulnerable Americans would be threatened. Finally, the bill includes funding for the state health insurance and assistance programs, the so-called SHIPs, S-H-I-P-S, which are also crucial to ensure that Medicare beneficiaries are empowered to make the best decisions for their health care needs. I raised this issue during our last hearing on Medicare Advantage marketing, and I appreciate this funding cliff will be addressed. Thank you, Mr. Chairman.
Thank my colleague for his good work. Let's see, we're now at Senator Cardin.
Thank you, Mr. Chairman. I also want to join my thanks to you and Senator Crapo for advancing this bill. It continues our committee's responsible actions to deal with the high cost of drugs, which is critically important. It's one of the largest parts of our healthcare system, and certainly the fastest growing. And improvements in mental health and behavioral health, which is so needed, comes out of the work of our working subcommittees for mental health. I want to thank all those that were involved in it. The Medicare, the extenders that are in this package is also important. Thank you for including the recommendations of our subcommittee on telehealth. That's important. The experiences we learned from COVID-19 show us that telehealth is an important part of a more accessible, affordable health care, and I was pleased that we were able to incorporate many changes into this bill. I have an amendment that would add the permanency of the exemption provided for in-person for telehealth services. It doesn't expire currently until 2024, which I understand the reason it was not included in the chairman's mark. But I would hope that we would make sure that we deal with the permanency of that exemption because it's important for the advancement of telehealth services, particularly in mental health. And then, Mr. Chairman, I was disappointed the bill that we are considering here today cut the Medicare Advance Alternative Payment Model in half. My home state of Maryland has one of the highest rates of physicians participating in value-based care. If we do not correct this cut, more than 5,000 Maryland providers will lose resources to continue providing innovative care models to their constituents. So I'm disappointed. I hope we can find a way to advance that. And lastly, let me say I join with Senator Bennett and Senator Crapo in offering an amendment to provide Medicare coverage and payment for multiple cancer early detection screening tests that are approved by the Food and Drug Administration that are used to screen for cancers across many cancer types. This is groundbreaking. We'll be able to get early detection for cancers today that are basically death sentences that will give hope. And I hope that we'll be able to get that legislation to the finish line in order to be able to save lives. Thank you again for your courtesies.
We'll continue to work with you on the very constructive suggestions you're making for going forward. We tried to get as much money for the alternative payment programs in as we could, and we'll be back in the next Congress. Okay. Senator Johnson, I understand you'd like to make an opening statement.
Yes.
Colleagues, that'll conclude opening statements then.
Thank you, Mr. Chairman. First of all, I want to thank Ranking Member Crapo. I think he's been doing an excellent job, he and his staff, at providing us very detailed weekly updates in terms of all the things being discussed here in the Finance Committee, either in committee or behind the scenes. But I'm new to the committee. Maybe this is a different way of doing business, but as I was made aware of this, we got the chairman's mark Monday morning. We got an update to it yesterday. Again, it's very detailed, but it's not legislative language. I don't have a whole lot of time to go through all this detail, and these are complex issues. I realize that during our markup on PBM reform, I'm the only one that voted no. And I think I stated at the time it's because, A, we ought to take the Hippocratic Oath here and first do no harm. Plus, and this also further talks, deals with PBMs, not necessarily in a helpful way. But I pointed out at that point in time that PBMs were initially the solution. That was going to lower drug costs. And we had a very interesting discussion in Republican lunch where Senator Rick Scott, who knows something about this, that ran Hospital Corporation of America, said that he had no negotiating power with drug companies until he was large enough to do it. So that's what PBMs are doing. They're large enough to actually negotiate lower price. And I think the proof is in the pudding that to some extent they're working because Big Pharma is all for the PBM reforms we're pushing. So again, these are complex issues. There's a lot that's being passed here. I don't have the legislative language. And again, shout out to Senator Crapo for providing a lot of detail. But I just have to say that I just can't vote on this. I'll either abstain or I'll just vote present. This is just kind of a strange way of doing business here. I hate to say that, but and again, I've got real doubts about what this committee is trying to do in terms of PBM reforms. Again, first do no harm. I don't know how else you're going to start bringing negotiating power into drug pricing until we actually introduce real consumerism, which we're not doing. Which is just one big group after another big group, and in this case, with the PBM reforms being suggested by this committee, the fact that Big Pharma is all for them speaks volumes. And that's not saying that smaller pharmacies aren't getting hosed in this process, but to me, it's determinative that Big Pharma is for the PBM reform. There's something wrong with that PBM reform then. Thanks.
So I just want to make one quick point because time is short. We put out, colleague, a full legislative discussion draft next week on everything we're talking about today. So there's been plenty of time to get into it. Now we're going to go to the period for colleagues to be able to ask questions. We've got multiple committee staffers available to answer questions. For the Senate Finance Majority, we have Ms. Marissa Salemi, Ms. Mariel Kress, and Ms. Eva DeGoff. For Senate Finance Minority staff, we have Connor Sheehy, Mr. Stuart Potman, Ms. Erin Dempsey, Ms. Gable Brady. We also have Dr. Phil Schwagel from the Congressional Budget Office, and Aisha Savos. Members have received the modification of the marks. Will dispense with a description. Senators are welcome to ask any questions of the panel that they choose. Any senators wish to ask questions of our very talented panel?
Mr. Chairman.
Senator Langford.
One quick question for CBO, if I may. Dr. Swigel, thank you. Thanks for all your team and for all the work that y'all have done working on the tiering aspect that we've tried to be able to work through. It's incredibly complicated, but it's focused on how do we actually get lower priced drugs to the consumer, to the counter. I appreciate this. This is the first time y'all have tried to be able to score something like this on this, so it's a lot of complications as we worked on this for years. I know this has been a top priority of the chairman and the ranking member. They've said it over and over again. I also understand you're working to be able to get some final scoring on it by the end of this month. I would ask for the opportunity to be able to interact as we're going through all the final scoring on it to see if there are tweaks, if there are things that you observe and see, hey, here's the problem, here's the issue, whatever it may be, so we can try to get this right at the end. Time is of the essence to be able to move this. I'm just asking for a commitment that when you get to that point, we have the opportunity to be able to have more than just a score, but also a dialogue, try to figure out how to be able to make sure it works.
Yeah, Senator Langford, you have that commitment. We'll have our analysis ready by the end of this month, and when we have it, we'll come to you, and we'll be happy to go back and forth and make any adjustments.
Great, thank you. Thank you, Mr. Chairman.
And I just want to say to my colleague, Senator Crapo and I are going to continue to work with you on this, so we're clear on that. Okay. At this point, we have...
Mr. Chairman, I've got a question if we've got some time here. The question I posed.
We don't have time, but we're going to make time for your question.
Well, I appreciate that. So again, the question I pose is if this PBM reform that this committee is considering and that we passed earlier is going to lower drug prices, and if you're really lowering drug prices, you're going to be taking something out of Big Pharma, right? Why is Big Pharma so supportive of these reforms?
Well, Senator, thank you for the question. I think I can't speak to a stakeholder group's perspective on this. I will say we've received a good deal of support from, as you mentioned, the pharmacy community, from the patient community. What I will say is, from a substantive reform standpoint, nothing in this bill would in any way undercut or undermine a pharmacy benefit manager's ability to negotiate discounts, negotiate price concessions or rebates. I think it's worth noting, for instance, Section 203 says the PBM and the plan sponsor simply need to allow the senior at the pharmacy counter to share in some of that discount. So from a patient perspective, you would be paying less at the pharmacy counter. The plan would still receive the majority of that rebate. They would still be able to negotiate that in private. They're able to adjust it at the margins. I think from a manufacturer perspective, what you would see is a more transparent price point. So insulin, for instance, you would see an 80 or 90% gap between the list price and the net price for years, and yet the list price was the basis for beneficiary cost sharing. I think this is a shift to a more transparent pricing model, and frankly, one where seniors could save, in some cases, hundreds of dollars at the pharmacy counter. So I think folks in general, as we worked on this legislation on our committee staffs and on the staffs of folks around this room, appreciated the value of trying to bring more transparency. I think they looked at cases where you'd see an 80 or 90% gap between the untransparent proprietary net price and the gross cost that was used as the basis for coinsurance, where seniors are actually paying a percentage of this inflated cost. And I think a lot of folks agreed we want to move to a more transparent model that's cheaper at the point of sale and that curbs incentives, as Senator Langford mentioned, for these plans to prioritize high list price, high rebate products, but not allow seniors to share in those rebates. And I would refer to, for instance, a recent GAO study that suggested that plans by and large, now there are exceptions, Kaiser Permanente is an exception, they use a net cost-based model. They also prioritize low-cost biosimilars. They've saved $300 million this year. Oh, I'm sorry, sir.
You have made an eloquent case for what Senator...
I apologize, Mr. Chairman.
But he didn't answer my question.
He did. He said specifically, Senator
really
Johnson, he talked about the hundreds of dollars that consumers, seniors, and others would save. So we're going to move on now. A quorum for the purpose of conducting business under Committee Rule 4 is present. That being the case, the modification is hereby incorporated into the chairman's mark, and the chairman's mark is modified as open to amendment. We're going to go back and forth, colleagues, Republican and Democrat. We will start with a Republican amendment or a colloquy? Does any senator wish to offer an amendment on the Republican side?
I do, actually, Mr. Chairman. This is the one that Senator Menendez and I have worked on for years on this. This deals with the issue of tiering. This is the issue of how do you actually get access to biosimilars. What Senator Menendez and I had actually started with was generics, biosimilar, specialty drugs to get all that included. That went through a CBO process. We have then gone through the process to be able to narrow that and tailor that down to just the biosimilars. As they are quickly coming on the market, many of them are dramatically cheaper, and we want to make sure they actually end up on the formularies. Mr. Chairman, I would like to add in a few items for the record. Civica, in a letter that they have submitted, the Biosimilar Forum, what they have submitted, and then the HHS Office of Inspector General did a report in 2022 titled Medicare Part D and Beneficiaries Could Realize Significant Spending Reductions with Increased Biosimilar Use. I'd like to add all these three to the
Without
record.
objection, so ordered.
The amendments that we have, we understand that this is going to be included, if at all possible, on it. What we're trying to do is to be able to drive down the actual cost to consumers at the counter, as well as the cost to the federal government and the taxpayers as well. I do appreciate all the staff's commitment to this. This has been a very long process to be able to work through this. But based on the evidence that we have seen going through this from the HHS, OIG, and from others that have examined this, I expect this policy to actually come back and save the government money because it drives down patient costs and it continues to drive down net prices as the branded price has to compete with a lower cost biosimilar. Simply stated, this would allow for when a new biosimilar comes on board, if it's the net price is significantly cheaper, and we're basing that off what's called the wholesale acquisition cost, it allows that to be able to be on the formulary, so we're actually increasing competition rather than biosimilars being forced out into the benefit of branded higher priced drugs that we actually increase competition. It's the basic principle of we want more competition, not less. We want more options for seniors, not less in this. And so we are submitting this as an amendment today. I understand that it's still working through the final process with CBO to get final scoring, so I'm not going to ask for a vote on this today, but we think it is essential to be able to get this policy in.
You've been doing very good work on this. Let's recognize Senator Menendez, and then Senator Crapo and I will respond about how we're going to be working with you. Senator Menendez.
Well, thank you, Mr. Chair. And during the committee's PBM markup in July, I, along with Senator Langford, spoke about our legislation that would address unfair pricing gimmicks that only hurt patients at the pharmacy counter. And at the markup, you, Mr. Chairman, and the ranking member committed to working with us on this policy, and I very much appreciate both of your support and partnership, as well as that of the committee staff, as we work together to modify these provisions based on feedback from CBO. Under the current PBM and Medicare Part D plan structure, often a biosimilar drug, which should come with a lower price tag at the pharmacy counter, actually costs as much or more than the brand name drug product. That is, if the drug is even covered by insurance at all. Currently, many contracts explicitly block coverage for the most affordable biosimilars. That's just simply not right. This policy will ensure seniors can finally benefit, and financially, from lower-cost biosimilars instead of being forced to pay for higher-priced drugs solely because of pricing tactics used by the drug pricing minimum. So I appreciate the Chair and Ranking Member's commitment to seek to include these provisions in the PBM package the committee moves to the floor, and I've enjoyed working with Senator Langford in this regard.
And let me just be clear on this. We support the proposal that's being made by our two colleagues to break the PBM logjam and increase access to lower-cost biosimilars, and I'm going to recognize Senator Crapo for anything he'd like to say.
Yeah, I would just like to thank Senators Langford and Menendez for your leadership on promoting patient access to biosimilars. Economists broadly agree that without this type of pro-competitive policy, low-cost biosimilars will continue to face coverage and placement barriers. The short-termism and gamesmanship of the annual PBM contracting bolsters preferences for higher-priced products, forcing both seniors and taxpayers to carry the burden. Senator Wyden and I have reserved savings in this bill as needed to ensure that we can advance this proposal, but I concur with OIG and a host of experts. This policy is a savings driver and a game changer. We're committed to getting this done.
I thank my colleague, and we are going to get this done. Let's go now on the Democratic side to either an amendment or a colloquy. Senator Stabenow, did you have a?
I do have something
colloquy?
briefly, Mr. Chairman. First, I have two amendments that I will not offer, but one would make sure going forward that the certified community behavioral health clinics are defined in Medicare. We did it in Medicaid today, but not Medicare. I understand there were some reasons for not doing it today, but it's very important we get it done. And the other amendment, which is so important, and I really want to work, Mr. Chairman, with you on our ranking member next year on as well, to ensure stability in payments for home health agencies in Medicare. This amendment that I have would provide a one-year pause to payment cuts currently facing the home health industry. We've heard in testimony before this committee about the challenges facing providers and patients in the home health care sector. We know that when people have the opportunity to get care in their home, that is their preference. And so I'm hopeful, Mr. Chairman, that we can work together to address access to home health care and the cuts that have been proposed.
Senator Stabenow, you've been our champ on community mental health programs and also on home health, and we'll be working closely with you on both issues.
Thank you.
Okay. No more colloquies apparently on the Republican side. I'm going to the Democratic side, and Senator Menendez will be next.
Well, thank you, Mr. Chairman. In the interest of time, I want to call up in block two amendments, Menendez 1 and Menendez-Stabenow number 2, and speak to them briefly.
Senators recognized.
Menendez-Stabenow number 2 is regarding resident physician shortage reductions. Patients and family members, communities throughout the country, doctors, nurses, providers are all grappling with the reality of the depletion of the physician workforce in our nation's healthcare system. By 2034, according to the Association of American Medical Colleges, the demand for primary and specialty care physicians will exceed supply by a range of anywhere between 37,000 and 124,000 physicians. Growing concerns about physician burnout, pandemic-related trauma, stress, anxiety, frustration suggest that many physicians may accelerate rather than delay their retirement. Given the considerable time it takes to train a doctor, coupled with the aging physician workforce, the time to invest in training more doctors is now. I've long championed legislation to address the physician shortage by increasing the number of Medicare-funded graduate medical education slots. This bipartisan policy would support critical training opportunities needed to alleviate the physician shortage and improve access to health care, particularly in rural or underserved communities, which in turn promotes healthier lives. I want to urge the committee to prioritize addressing the physician shortage. I know the chairman has worked with me in the past in this, and increasing the number of GME slots in any end-of-the-year package. Lastly, family-to-family health information resource centers are indispensable for families and children with complex care needs. As implied in the name, these centers provide families with the support, help, and assistance they need to overcome adversity. And without them, parents can be left to struggle alone, unsure of where to turn for the information of guidance they need to manage their child's health care. Importantly, the staff at these centers are often parents themselves, so they understand the unique needs of parents who want to best support and advocate for their children. Among the services they provide, family-to-family centers offer greater access to early and continuous screening, education, technical assistance, and peer support. The funding is the foundation for these essential centers in every state and territory, which is why we must extend their funding this year. And I look forward to working with the chairman and the ranking member on both of these items.
I look forward to working with my colleagues. So here's where we are. We have a quorum to get this bill out of committee. We have 4 colleagues on the Democratic side who would like to offer colloquies. I'm available to listen to all of them. We can also vote and have your colloquies after the vote. Is that agreeable to colleagues? Okay. We've got at least 15 members present. I move that the chairman's mark, as modified and amended, be reported favorably. Is there a second?
Second.
Clerk will call the roll.
Ms. Stabenow. Aye. Ms. Stabenow, aye. Ms. Cantwell. Aye. Ms. Cantwell, aye. Mr. Menendez. Aye. Mr. Menendez, aye. Mr. Carper.
Aye by proxy.
Mr. Carper, aye by proxy. Mr. Cardin.
Aye by proxy.
Mr. Cardin, aye by proxy. Mr. Brown.
Aye by proxy.
Mr. Brown, aye by proxy. Mr. Bennett.
Aye by proxy.
Mr. Bennett, aye by proxy. Mr. Casey. Mr. Casey, aye. Mr. Warner. Mr. Warner, aye. Mr. Whitehouse. Mr. Whitehouse, aye. Ms. Hassan. Ms. Hassan, aye. Ms. Cortez Masto. Ms. Cortez Masto, aye. Ms. Warren. Ms. Warren, aye. Mr. Crapo.
Aye.
Mr. Crapo, aye. Mr. Grassley.
Grassley's on his way. Can we skip him for now?
Mr. Cornyn.
Aye by proxy.
Mr. Cornyn, aye by proxy. Mr. Thune.
Aye by proxy.
Mr. Thune, aye by proxy. Mr. Scott.
Aye by proxy.
Mr. Scott, aye by proxy. Mr. Cassidy.
Aye by proxy.
Mr. Cassidy, aye by proxy. Mr. Langford. Mr. Langford, aye. Mr. Daines. Mr. Daines, aye. Mr. Young.
Aye by proxy.
Mr. Young, aye by proxy. Mr. Barrasso.
Aye by proxy.
Mr. Barrasso, aye by proxy. Mr. Johnson.
No instruction.
Mr. Tillis. Mr. Tillis, aye. Ms. Blackburn. Mrs. Blackburn, aye. Mr. Chairman.
Aye.
Chairman votes aye.
Grassley will be aye by proxy.
Mr. Grassley, aye by proxy.
The clerk will report.
Mr. Chairman, the final tally is 26 ayes, 0 nays.
The bill is reported favorably. I ask unanimous consent that the staff have the customary authority to make appropriate technical, conforming, and budgetary changes. Without objection, I thank all members and staff. The meeting is adjourned. I'm going to stay to hear the colloquies from all 4 Democrats, and Senator Crapo will stay too. So we'll begin with Senator Warner.
Thank you, Mr. Chairman.
And I thank my colleagues for all their patience.
Thank you,
Senator
Mr. Chairman, and thank the
Right
ranking.
down the line.
Thank the ranking member and thank the staff, because I know you're anxious to hang on every word that we're about to lay out here. If I'd had a chance to do opening, I would have congratulated you on the PBM work. I'm not going to do that. I was going to also talk about the advanced alternative payment model to make sure we get that bonus payment right to incent the right kind of behavior. But moving to my amendment, Warner Scott number 1, which would include in the underlying bill a definition in statute of long-term care pharmacy. It would mean in the future, Congress can tailor policies specific to long-term care pharmacies when necessary. It's based on legislation that Senator Scott and I had. We had 21 co-sponsors, 11 who were finance members. I'm grateful for the chair and ranking member's support for the bill over the last year. We tried to get it in last year, but it didn't clear the House. Particularly Chairman Wyden, your staff has worked closely with mine this year on updated language. I know we're close to finalizing it. Wasn't ready for the markup, so I'll be withdrawing the amendment, but knowing we're close, and this has been a multi-year process. We're just trying to get a definition on long-term care pharmacies in. I hope you can prioritize it for this year's end-of-year package.
At the end of this. I thank my colleague, and I want my colleague to know I think your idea of trying to bring consistency to how these pharmacies are being regulated is just common sense. I look forward to working closely with you.
I'm going to take that as a yes to get it in the end of your package.
As much as yes as I can make.
Will withdraw my amendment. Thank you,
Great.
Mr. Chairman.
I thank. At this point, Senator Carper, I believe you would like to be recorded formally.
I would ask unanimous consent. I recorded formally, yes.
Great. Terrific. Senator Whitehouse, right down the line.
Thanks. Thank you very much, Chairman Wyden. I would call up White House Amendment 1, co-sponsored by Senators Barrasso, Cardin, Thune, Warner, and Cassidy. This bipartisan amendment supports the innovative providers in alternative payment models, referred to as APMs. My favorite one happens to be the Accountable Care Organization, because we've had outstanding success with ACOs in Rhode Island through the work of Integra and Coastal Medical. But it's not just Rhode Island. In 2022, ACOs generated $5.2 billion in gross savings and $22.4 billion in gross savings over the last decade. So it is a very significant efficiency for Medicare and CMS, but there is much more that needs to be done, because the real benefit of an ACO is not measured in its savings to Medicare. It's measured in its improvement to the quality of care for the patients of the ACO. The reason you're seeing these savings is because patients are healthier. and in many, many respects, their lives are made better. We have seen firsthand in Rhode Island what a remarkable transformation it is when doctors get off the fee-for-service treadmill and deal with patients as real people and have the flexibility to find ways to make them healthier, whether it's home visits from social workers, whether it's replacement of slippery carpeting on the stairs, whether it's home telehealth facilities installed, whatever it takes, overview of their multiple pharmaceutical needs and better coordination of those. All of these things make the patient experience better, make the patient's health better, and we can do more to support the ACOs. They haven't been given the full support that they deserve. So knowing that APMs can improve patient care and lower costs while financially rewarding chronic care coordinators, primary care providers, and nurse care managers who really represent the backbone of our healthcare delivery system. Before we make significant changes to the structure of APM bonus payments, we first must have a conversation in the short term about how we can continue to incentivize providers to participate in value-based care arrangements. Will you work with me and Senator Barrasso and our multiple bipartisan co-sponsors to see that this gets done?
This is an easy yes, Senator Whitehouse. The fact is you have been toiling on these alternative payment models for ages, and dollar for dollar, they're one of the smartest investments we make in American healthcare. They fit very well with chronic care. As you know, we got the amount up by $700 million for 2024. We're going to keep working with you to increase it, I think.
I thank you, Chairman, and look forward to success as this moves to the floor. Congratulations on your success with this bill today.
Thank you for your good work. Senator House.
Well, again, thank you, Mr. Chair and Ranking Member Crapo. I'd like to offer my amendment Hassan number 2, which would end the practice of charging patients unfair hospital facility fees for care provided in the off-campus outpatient setting, like at a regular doctor's office. Healthcare costs are too high, and this is in part due to unchecked consolidation of hospitals and physician practices. Increasingly, hospitals have been buying primary care and other community-based practices, and right now, hospital-owned doctors' offices can charge higher fees than independent doctors' offices. As a result, some patients have found, even though that they are visiting the same facility, receiving the same treatments, and even seeing the same doctors before, they are being billed double overnight. This burdens patients and the Medicare program with unfair, steep costs for routine, everyday care. In theory, Congress already banned the practice of charging hospital rates in a community setting, but a loophole in the prior law has meant that it does not help as many patients as Congress intended. My amendment would close this loophole and save taxpayers tens of billions of dollars over the next decade. With this amendment, we can lower costs for patients and invest in substantial bipartisan health care priorities, including building the nursing and physician workforce. Chair Wyden and Ranking Member Crapo, I understand that you would like more time to work through the technical aspects of this policy, and I am certainly willing to withdraw this amendment for now. But as I do so, I hope you will commit to facilitating a bipartisan committee process, including discussions, briefings, or roundtables with experts to consider and advance site-neutral payment policies that end unfair facility fees.
We'll both be working closely with you, Senator House, and we have had experts telling us, people that we respect, saying hospitals are charging higher prices for services based on where a service is delivered. So there's credible evidence of this kind of issue, and it leads to higher costs, and you don't get better outcomes. So you get kind of a double whammy. So we're going to be working with you to look at the evidence to see how to proceed. Senator Crapo.
No, I agree. This is one of those issues I mentioned earlier that we need to get done. We will work with you.
Thank you very much.
Thank my colleague, Senator Cortez Masto.
I'm looking for the same response. I call up. Me too. I call up Cortez Masto Cassidy Warren number 1. It's the inclusion of certain information in Medicare Advantage encounter data. Listen, we've all talked about this. The issue of transparency in Medicare Advantage is increasingly important to all of us. I know so many Nevadans, this is a popular program for my seniors in Nevada. They like it. They also should have the freedom to choose because, quite frankly, there are thousands of seniors in Nevada who rely on the traditional fee-for-service Medicare program that they need. That's why it's, I think, a priority for many of us to make sure that the entire Medicare program is sustainable and solvent. I am concerned, however, that we're paying more for Medicare Advantage than for similar benefits delivered under traditional Medicare. In 2023, $450 billion, or 54% of total federal Medicare spending, went to Medicare Advantage. There's billions of federal dollars flowing to private health plans, and we need to be conducting better oversight if we're going to make policy changes that support all Medicare beneficiaries. That's why I'm offering this amendment that supports transparency and MA plan provider directory oversight. While CMS already requires MA plans to submit encounter data, there is little transparency about plan performance in that existing data. My amendment requires the MA plans to submit encounter data that includes information on payments to providers, cost sharing for beneficiaries, and services provided by companies that are vertically integrated with those MA plans. It includes several recommendations from OIG to make encounter data more useful so we can actually follow the federal dollars and how they are being spent by MA organizations. It would also, this policy would strengthen what CMS is collecting in encounter data to expand what is publicly available to policymakers and research. Now, I understand from the chairman and ranking member, you'd like more time to work through the policy and the amendment, so I plan to withdraw my amendment today, but I intend to introduce it in bipartisan legislation, again, with the support of my colleagues, and I hope that both the chairman and ranking member can get a commitment to continuing to working forward on this issue and understand your concerns.
Look, there is so much that needs to be done to shake up these MA plans, and certainly making sure that Medicare has the information to determine whether seniors are getting what they need is critical. We've been looking at these middlemen. We got a big chunk of the proposals made by members of this committee. There's still more to do. So the answer to your question with respect to having Medicare get the information so we can make sure that the Medicare guarantee is really being honored is key. So the answer is yes. Senator Crapo?
Yep, and I agree with Senator Wyden. I'll be committed to working with you to advance this proposal in a fiscally responsible and bipartisan way.
Okay, Senator Warren.
Down to me. So I would like to call it two amendments today. First, Warren Grassley
without
amendment.
objection, so ordered.
But I'm going to still talk about it for a minute.
Yes, that was not to stop you.
This is important, though, because what this is about is removing the outdated rules in Medicare that prevent seniors and people from disabilities from accessing the full range of hearing and balance health care services provided by licensed audiologists. My bill with Senator Paul and Senator Grassley, called the Medicare Audiology Access Improvement Act, would allow audiologists to provide all the services that are already covered by Medicare that are also within an audiologist's scope of practice. It would also remove the barriers to care that currently force Medicare beneficiaries to jump through more hoops than people who receive their health care coverage through the VA or the Federal Employees Health Benefit Program or commercial insurance. This matters because adequate care for hearing loss is an important part of supporting our seniors. There is substantial research linking hearing health with mental health. Untreated hearing loss has been shown to lead to depression, anxiety, loneliness, and social isolation. Studies also suggest that hearing loss may be one of the greatest risk factors for developing dementia. Seniors with hearing loss experience cognitive decline up to 40% faster than those with normal hearing. And older adults with moderate or severe hearing loss are 3 to 5 times more likely, respectively, to develop dementia. If we're working to strengthen support for seniors' mental health and mental acuity, then we should include access to health care aimed at treating hearing and balance disorders. Now, I'm going to withdraw my amendment because it does not meet the germaneness standard that the committee has adopted for this markup. But, Mr. Chairman and Mr. Ranking Member, I am asking for your commitment to work with me and with Senator Grassley to advance this common sense bipartisan bill in future legislation.
Thoroughly. And, you know, I was just trying to get from the staff a little bit of an update on sort of what is actually out there now. And I mean, other than the cochlear implants, there's, you know, very little. And I'll just tell my colleague, 10-second story. When I taught gerontology and got a few $100s coming in to do the Gray Panthers, I would give on an exam what Medicare covered. And people would always say it's only half a loaf because it doesn't cover hearing and many other kinds of services. So you're spot on, and the answer is yes, and Senator Crapo has indicated to me, and I'll let him speak, that he wants to work with us too.
Definitely. As we mentioned yesterday when we spoke, I completely agree with your observations about the need to deal with this issue.
Good.
And I look forward to working with you to see if we can get this done.
Good. I so appreciate this, and I just want to say, frankly, I think we should do more to prioritize hearing health for our seniors, including by expanding Medicare hearing coverage. But I'm sticking with the subject that we're talking about today, and at a minimum, we should ensure that Medicare beneficiaries can readily access the full range of hearing services that Medicare already covers. So next, I'd like to turn to the Medicare Advantage program. I want to echo Senator Cortez Masto's support for our amendment with Senator Cassidy to improve Medicare Advantage encounter data, and I hope we can keep working on this in future packages. I appreciate her leadership on this. But I'd also like to offer Warren Cassidy number 2, which would require CMS to collect and publish data from Medicare Advantage plans on their prior authorization practices. You know, currently, there are no data on the number of prior authorization requests, denials, or appeals by type of service, including mental health and substance use disorder services. This means that we cannot answer basic questions like, are denials more common for certain kinds of services, or certain Medicare Advantage plans are improperly denying care more than others? Let me be clear. I strongly believe these data should be available for all types of services, both physical health and behavioral health. But as the committee rightly focuses on behavioral health in this markup, I hope we can all agree that this is a step in the right direction. And while I'm withdrawing this amendment, I look forward to working with the committee, working with our chairman and our ranking member to close these data gaps in Medicare Advantage so that seniors have the information they need to get the coverage that works best for them.
So my colleague is talking about a very important issue. I mean, we talked a little bit about related matters when Senator Bennett's issue came up with respect to the ghosts, and I know you've been going after them rightfully, and in my view, as I have been. The insurance companies are just burying the hospitals and the doctors and patients in mounds of red tape. And I'm actually doing an investigation now on how insurers are overusing prior authorizations in Medicaid. And the Inspector General has reported on some very serious practices going on in these government programs. So I want to work closely with you to deal with what are very obviously barriers to care for vulnerable people. Senator Crapo.
Well, thank you, and I agree. I'll also be glad to work with you on this. As you know, I'm a big proponent of Medicare Advantage, but it doesn't mean that I like the prior authorization process and that I don't see some problems here that need to be solved. So I'll be glad to work with you on that.
All right. My colleague, anything else? All right. Well, we're now adjourned.